All right, Jesse, whenever you're ready.
Sure. All right. So I'd like to introduce Dr. Michael Alosco, who is presenting our talk today. Mike is an associate professor of neurology and co-director of the clinical core with me. Mike and I work together on a huge number of projects, and I couldn't think of a better person to give this talk and to work with me. The title of his talk is Vascular Contributions to Cognitive Impairment and Dementia in Former Context Sport Athletes.
All right, thanks, Jesse. Appreciate those words. So first, I do have a disclosure. If I suddenly start not making sense or falling asleep, it's because we just had this little guy last week. Oh. So please, and this is also the first time I'm giving this talk, so the combination is probably not a great combination, but we'll see how it goes. So just a little background on what we're going to do. What we're going to talk about today. So first, I'm just going to start off briefly going over repetitive head impacts, lay down some terminology, and what we know about the long-term effects of repetitive head impacts. And then I'm going to jump into a topic that's been near and dear to my heart since graduate school, actually. I started off, actually all of my doctoral work focused on cardiovascular disease using heart failure patients and how that impacts brain aging or accelerates brain aging, specifically cerebral perfusion and white matter hyperintensities in that population. And I've since transitioned that work to really focus on neurodegenerative diseases, now including CTE and repetitive head impacts. So we'll go over kind of what we know about white matter and microvascular injury in the setting of repetitive head impacts, both pathologically and then also some of the latest, some of which is not even published yet, using in vivo imaging, and also the plans for where we're going to go next, or where I think we're going to go next. If anyone has any questions, please feel free to interrupt and keep it informal. So just a little bit of terminology. So traumatic brain injury, I think most are familiar with this term. This is a table from the CDC and the VA DoD. We've typically thought about TBI as any kind of force that's applied to the head or neck that causes some type of injury to the body, to the head or to the brain, I'm sorry. And there's 3 different severity levels: mild, moderate, and severe. Most commonly, you'll see, at least in the Alzheimer's disease literature or other or similar settings, you'll see severity defined by loss of consciousness, with 30 minutes plus being moderate to severe, and then anything less than 30 minutes being mild. But there are other ways to define it, including the Glasgow Coma Scale, duration of post-traumatic amnesia, and so on. So we typically think of a TBI resulting in 4 types of signs and symptoms. You have the somatic, so they can include loss of consciousness, the sensitivity to light, sound, headache, nausea. You also have sleep disturbances are quite common. Cognitive, memory problems with attention, executive function, and then you also have some mood problems, depression, irritability. And again, these are signs and symptoms that typically happen right after the TBI, so they're acute. I really like this figure that displays the typical acute recovery from TBI and the different severity levels. So you can see on the y-axis here, the top here is the baseline, or the person's pre-injury baseline. And then here the event, the TBI happens with different symptoms. You can see here that with a mild TBI, typically within a week, the person fully recovers, is back at their baseline. Note that there are a small subset who go on to have symptoms for months or even a year. And then moderate TBI, it takes them much longer, and most don't even actually reach their baseline, perhaps. Some do, but it takes them much longer to get there. Than severe TBI, most do not go back to their baseline. Another form of TBI that we've been really studying now is subconcussive blows, and this is specifically a subset of a mild TBI. And this is it's an impact to the head that we think causes neuronal injury, but it's not enough force to cause symptoms. And these are the types of hits you see in contact sports, specifically American football. You can think of the linemen kind of lining up and banging their heads on each other, on most downs, most plays, every practice. And these are the types of hits that we've come to know that are really problematic, particularly when they're repetitive. And repetitive head impacts is what we've been studying. So these are hits to the head that are repetitive, and they result in recurrent concussion and also the subconcussion. So you have the concussion or the mild TBI that results in the symptoms, but then you also have these subconcussive events that have no symptoms. And again, these are the repetitive nature. These are thousands. A former football player who plays at the college or NFL level can have thousands and more throughout their career. And we think that these types of repetitive head impacts are causing long-term problems. This was a recent paper we published back in 2019 or 2020, I'm sorry. So this specific paper, the goal of it was to look at how repetitive head impacts lead to later life problems, as well as how they interact with traumatic brain injury. Symptomatic traumatic brain injury. And what we did was we used the Brain Health Registry. And the Brain Health Registry, you can kind of go online right now and Google it. But it basically follows more than 70,000 people now across the country. It's run out of UCSF by Dr. Weiner. Its goal has really been to facilitate people who are interested in getting involved in Alzheimer's disease research and clinical trials. But within this Brain Health Registry, there's also a question on traumatic brain injury. Specifically, they use a modified version of the Ohio State University. And there they ask, have they had TBI? They also ask, they also have a question about if the person has ever had exposure to repetitive head impacts through contact sports, military service, or domestic violence. And so we decided to look at these TBI questions in this really large sample and see if it was associated with any measures of thinking and memory and mood. So everyone who signs up for the Brain Health Registry, they complete three. At the time of the study, they completed 3 computerized cognitive test batteries, and they complete that every 6 months. In addition to quick measures of mood, so the geriatric depression scale, and then they also complete, a bunch of demographic, medical, and other history questionnaire. And so at the time, there was about 60,000 people in the Brain Health Registry. And we ended up dwindling that down to about 13,000 after, we were actually one of the first to really dive deep into this database, and it took quite a long time. But after we got rid of non-plausible cognitive test data, we restricted to people who were 40 or older, mostly because we're interested in the long-term effects. And the registry actually spans from 18 and above, although most people are older. And then we also, the OSU TBI measure was not implemented in 2015, so we had to restrict it to those people. And then we took care of missing data and so on. And so then we had a final sample about 13,000, but then we had these different combination of groups. We had people who did not have any history of repetitive head impacts or TBI. And then we had different combinations of those. So some with repetitive head impacts, but no TBI, some with repetitive head impacts, but who had TBI, but no loss of consciousness. And then those with repetitive head impacts and TBI with loss of consciousness, and those with just TBI. And so we were able to look at these 6 groups to test how they might affect later life cognitive function and depression. And this is just some examples of the findings or the strongest effects we found. So if you look at the geriatric depression scale, you see that those, and actually an important a really important methodology component to this is that each of these groups were propensity score matched on demographics. So they were all similar in terms of their age, sex, and education level. But what we see here is that those who had a history of repetitive head impacts were more likely to have higher scores in the GDS, so more likely to have more depression symptoms, as were those people who had TBI, both with and without loss of consciousness. And interestingly, if you look here on the right, there was kind of a dose response relationship with the GDS and repetitive head impacts and TBI. That is, as people had repetitive head impacts and more TBI or more severe TBI, their scores in the GDS went up. With the group who had both repetitive head impacts and the most severe TBI having the most symptoms of depression. And we found a similar finding with cognitive function, although not as strong. Specifically, those with repetitive headaches had worse performance on this test of reaction time, working memory, and it kind of, you see a similar kind of dose response relationship, though again, it's not as strong as depression. So I was really excited about that work. You know, other research before that has shown a relationship between cumulative exposure and repetitive head impacts and symptoms of memory loss and depression and other behavioral disturbances. But that is the largest study, I think, still to date, really looking at these different combinations of injuries. But now the next kind of logical question is, do these repetitive head impacts lead to neurodegeneration or neurodegenerative disease? And that's another area that the whole center has been focused on, and here is specifically chronic traumatic encephalopathy. So this work has been obviously led by Dr. McKee here, who defined CTE as a neurodegenerative disease characterized by the phosphorylated tau around blood vessels that are typically at the depths of the sulci here. So this is the unique pathognomonic lesion of CTE. Jesse Mez has characterized the relationship between repetitive head impacts and CTE risk. Specifically in 2019, he looked at the relationship between duration of play as a metric of repetitive head impacts and risk for CTE status, and found that the odds of CTE increased by 30% for each additional year played. And there was a similar kind of effect for CTE severity, in that the odds also of developing severe CTE increased by 14% for each additional year played. So that research has really established repetitive head impacts as being a necessary risk factor for CTE. And we know that through a bunch of other research at our center as well. Other current research in the center is really focused now on figuring out ways that we can develop biomarkers to detect CTE during life. One project that I'm working now is looking at the tau ligand MK6240 to see if that can pick up the pathology of CTE during life using PET imaging. Jesse and I also have a paper under review that characterizes structural MRI profiles of CTE. That is actually decision pending right now. I just checked. So hopefully we hear it back soon. So this will be this. I bring this up because this is just kind of where we are currently with the status of the literature for CTE. Bob Stern has also been doing a lot of great work with imaging and biomarker, including Diagnose CTE research project. Now, the clinical presentation of CTE is also becoming increasingly well defined. These were just published in 2021. So really there is a constellation of symptoms for CTE. So Dr. Katz, as well as Dr. Stern, they published the Traumatic Encephalopathy Syndrome Research Diagnostic Criteria. So these were an update from 2014. These are really meant to facilitate research on the clinical presentation and disorder of CTE, and and they're not ready for the clinic yet. But basically what they they're a little bit complex, but what it boils down to is having cognitive impairments. These include impairments in episodic memory, executive function, in addition to neurobehavioral dysregulation. So these types of symptoms include emotional dysregulation, explosiveness, impulsivity, rage, violent outbursts, short fuse. And then there's also functional impairment, so trouble with activities of daily living. And then there's also a list of supportive features, so motor signs, anxiety, apathy, depression, paranoia. Perhaps one of the biggest difference in these criteria from 2014 was moving depression from a core feature to more of a supportive feature. But these symptoms have really been born out of the research from the CTE Center at BU, where we've been doing clinical pathological research and also human subjects research in former symptomatic NFL players, where we're trying to characterize their symptoms prior to death and correlating it with CTE pathology. And these are the symptoms that we see most commonly in this population. Now, we now have some research that directly links the pathology of CTE with symptoms. So this was something we published in 2020, where we looked at the McKee CTE staging scheme. These were 359 brain donors with CTE, about 60% of them who had dementia. And we found a direct link between the stage of CTE. So there's 4 stages of CTE, 1 through 4. Now it's kind of more high or low. And each stage is associated with increasing tau pathology. But we found between each stage, there was a 1.64 times increased odds for having dementia at the time of death. And so you can see here that stage 4, brain donors stage 4 CTE, about 43% of them had dementia. And here's some pathology pictures of people with dementia and B and D who had severe CTE in the frontal cortex and the hippocampus compared to those mild CTE who are without dementia as well. And there's been a few other studies too from our center who also directly link the pathology of CTE with dementia or other symptoms as well. But we're also now increasingly seeing that not all of the symptoms of CTE are associated with PT, phosphorylated tau pathology, or at least not fully associated with them. And in fact, this was just published again by Jesse, and it just came out last week, I think, and where the goal here was to look at the clinical correlates of CTE pathology in brain donors from UNITE. And this included 336 brain donors, 244 who had CTE. And kind of the take-home message here, well, at least for the purpose of this talk, was that the cognitive symptoms had a strong association with the increased odds for CTE pathology, but the behavioral, the mood, and the motor symptoms were not associated with CTE pathology. And there's some other data that from our center that's not yet published that's kind of showing a similar trend that suggests that many of these symptoms, particularly the non-cognitive symptoms, might not be fully accounted by the phosphorylated tau. And in fact, even when you look at the Alzheimer's disease literature, there's more and more appreciation that the symptoms are really a function of mixed pathologies and not just isolated proteins. And so if we think about the model of CTE here, I like this framework. We definitely see the middle part here where CTE neuropathology is a function of exposure to repetitive head impacts, and we've tied that pathology to clinical symptoms. But we've also now know that repetitive head impacts, again, this is in part through Dr. Steen's work, that repetitive head impacts leads to a host of other neuropathologies, and these neuropathologies also contribute to clinical symptoms. But unfortunately, we still don't have a great grasp on the etiology of the different clinical features in CTE above and beyond phosphorylated tau. And really, having a better understanding of this will I think, open up different pathways for potential prevention and therapy. And that's where kind of the remaining of this talk comes into play, is focused more on white matter and microvascular disease. So just a few basics on white matter that probably most of you know here, but just in case. So 60% of the brain is made up of the white matter. And so if you look down here at this neuron and cell body, this is the white matter that I'm referring to here, the millions of bundles of axons. And this is really I think a focus in this setting of repetitive head impacts, because we know that this diffuse axonal injury is cardinal pathology of traumatic brain injury. So if you think about when a TBI occurs, you have these rotational forces. Those rotational forces really cause a lot of strain on these long axons and cause rupture, cause tear, cause shearing of them. And a lot of that has been thought to be the reason why people develop symptoms after TBI. And then beyond the axons too, we also have a lot of blood vessels in our brain. So this is focusing on the microvascular nature of CTE as well. So as I was mentioning, you have these forces that happen during TBI, and you have these long axonal bundles that are susceptible to these forces, but you also have all these blood vessels too, that are also these very long paths that can be susceptible to the shearing and tearing forces as well. And we know that CTE is uniquely perivascular. It has a unique accumulation of tau around small blood vessels. Dr. Goldstein has done some really fantastic work published in Brain. This was 2018, where they did experimental modeling to really show a microvascular component to head impact injury and the development of neurodegenerative disease pathology. So between the vessels and the white matter, I think it's a clear target for study in both CTE and repetitive head impacts. And this is not actually something new. This is a paper back in 1994, which is the title. It's kind of dug deep in the paper, so you have to read it. But within this paper, there are two boxers with dementia pugilistic, which we now refer to as CTE. But these two boxers, they were both in their 60s. And they were looking at the microvasculature, not only of these boxers, but they also had Alzheimer's disease and a bunch of other dementing disorders. But within these boxers, they had extensive microvascular fragmentation and loss of vascular branching in the frontal cortex. And they found a correlation between this microvascular fragmentation and the distribution of the neurofibrillary tangles. And here they actually hypothesized in the discussion that the head trauma from boxing precipitated the vascular damage that led to the accumulation of the tangles. So this hypothesis has been around now since 1994. And then fast forward now to the work at the CTE Center. What I'm showing you here are the different stages of CTE that's been characterized by Dr. McKee. Like I mentioned before, you have stage 1, where you have isolated foci of p-tau lesions that become widespread by stage 4. But within this, actually in Dr. McKee's brain paper in 2013, she describes it quite nicely. But across these 4 stages of disease, you also have progressive worsening of microvascular injury, white matter, and axonal and demyelination as well as the disease progresses. So in 2019, building on some of what we know about CTE and some of the earlier work that I showed you in the 90s, I wanted to look more closely at cerebrovascular, microvascular, and white matter injury in the setting of CTE using the Unite Brain Bank. And that's what we did with this paper here that was published in JAMA Neurology. Here we wanted to look at the association of white matter rarefaction, which I'll talk about a little bit more about what that is, and cerebrovascular disease with dementia using deceased former American football players, and they were older. So these deceased football players, they were from the Unite Brain Bank. There was 180 of them at the time of this study. They were, at the time of death, they were about 68 years old. About 19% were African American. They played, most of them played at a high level. Most of them had about 15 years of football play. Neuropathologically, most of them also had severe CTE, about 48% having stage 3. And then here within this study, we not only did we look at p-tau defined by the stages of CTE, but we also specifically looked at the frontal cortex. And you can see that about 50% had severe tau pathology in the frontal cortex. We chose the age of 40 for a couple of reasons for the sample. One is because we were interested in the long-term effects, and so we're trying to get at people who didn't just finish playing football or who were actively playing football. And two, people who were less than 40 really had no pathology, no dementia, so it did not make sense to include them here in this sample. Cerebrovascular disease. So again, we looked at a whole range of vascular disease in the sample. These are all rated by the neuropathologist, Dr. McKee, Dr. Steen, and Dr. Huber, and as well as Dr. Alvarez. And they rate these vascular components on a semi-quantitative scale: white matter rarefaction, atherosclerosis, arteriosclerosis. We also looked at microinfarcts, microbleeds, and infarcts, and so on. White matter rarefaction, we really use this as an overall or a global measure of white matter integrity. It refers to kind of demyelination, reactive astrocytes, and so on. And it's rated, and the pathologists rate it in the subcortical white matter of the lobes of the frontal, temporal, parietal, occipital lobe. Atherosclerosis is really more of a measure of a large vessel disease, and then small vessel disease with arteriosclerosis. These three variables here that I'm showing you were really a focus in the study, mostly because there was very few microinfarcts, microbleeds in the sample, and so few that we couldn't incorporate them into analyses. So here's just some images of what we were looking at in the sample. So here, if you look at B, that is an 85-year-old with stage 3 CTE who had dementia. And basically what that's showing is just a severe loss of myelinated fibers. C is as an example of in that same brain donor, arteriosclerosis. And then you have the tau pathology that was also examined in the study as well on the bottom row there. This is the classic lesion of CTE being shown. So this was the model we set out to test, and I'm going to break it down for you on the next slide. But basically, what we were trying to do here is understand two things. One, is white matter loss, rarefaction, is that a function of exposure to repetitive head impacts, and does that contribute to dementia or clinical outcomes? We already have seen the middle part of this figure. Specifically tau. We've seen that tau is associated with exposure, and that we also see tau is associated with dementia, but we also sought to include this relationship in our model as well. In addition to white matter rarefaction, we also wanted to look at other cerebrovascular markers, so that are more typically associated with things like hypertension or diabetes, such as arteriosclerosis. So if we break down this model, we start with this relationship, which is something we've seen before and something we see again here. Interestingly, though, what we show for the first time here is that the tau pathology, the effect of football play was on dementia was completely mediated by tau pathology. So we kind of put the three pieces of the puzzle together in this model. But we also saw that the more years of football play correspond to more severe rarefaction of the white matter. And in turn, that rarefaction also contributed to dementia. So the effect of football play on dementia was also partially mediated through white matter rarefaction. And then the arteriosclerosis, while it contributed to dementia, was not associated with football play. And so that makes sense to us because it was associated with hypertension, which is what you might expect here. And another really fascinating part about this study was that the effects of these different vascular pathologies on dementia were quite strong and quite comparable to those of tau as well. So really what we took home from this study was that dementia in CTE seems to be associated with various pathologies associated with the RHI, repetitive head impacts, like tau, as well as white matter rarefaction. But we also have these other pathologies that may not be associated with repetitive head impacts, like arteriosclerosis, that also contribute to dementia. I think we were excited about this finding, though, particularly about the white matter rarefaction, because anecdotally, we as the brain donors came in to the center, we continued to see a lot of this white matter pathology, and then this was a study kind of that put together the pieces that linked it with exposure as well as to dementia. Now, fortunately, we also have great new great imaging resources at our center to explore these relationships in humans as well. Actually, this scanner is a picture courtesy of Dr. Goldstein, who got this new scanner through Mass Life, I forget the full name, Science Award. And so this is a scanner that's just been installed and being used at the ADRC as well as I'm sure other centers. I tend to only think that there's one center at BU. So we're going to start using imaging to really get a better handle on white matter pathology and vascular disease in the setting of repetitive head impacts. This is something that's been studied at other centers, mostly though in active players. So here's I chose this study because I thought it was well done. This was a longitudinal diffusion tensor imaging study where they looked at changes in the white matter in college football players. Again, this was over the course of season, so it was acute, but they did find that repetitive head impacts just from a single season had effects in the white matter in college football players. And there's been other studies like this too. There's been studies in high school and youth football players as well, where just single season of head impacts is affecting the white matter. And then this was work also led by Dr. Stern back in 2015, where they also used diffusion tensor imaging to study the age of first exposure and its effects on the long-term effects of age of first exposure on the corpus callosum white matter microstructure. And in fact, they found that those football players, NFL players, among 40 of them, those who started playing earlier, so before the age of 12 specifically, had worse white matter microstructural, white matter integrity of the corpus callosum, specifically the anterior corpus callosum, compared to those who started playing later. And then further links, this was another recent publication. Again, this was with Dr. Goldstein, who's using DCE MRI to look at blood-brain barrier disruption. And they looked at it in Israeli amateur American football players, and they had a group of non-contact sport athletes as well. And interestingly, they found blood-brain barrier disruption using this DCE MRI in the football players compared to their healthy control group. What I thought was really cool about this study, though, was that those blood-brain barrier disruptions correlated with DTI white matter changes in the football players. So again, more evidence for the long-term effects of these repetitive head impacts on both the white matter and microvascular injury. So while DTI is great and it can pick up on subtle changes to the white matter, I think there are some limitations to it that are worth noting. One, I think the interpretation of the indices, specifically in the clinical setting, are not clear, and that's why it's actually not FDA approved, at least in the setting of Alzheimer's disease, for use. The processing can be laborious, and there can be a lot of manual methods applied with a lot of variation across labs that can affect reproducibility. It can be very sensitive to scanner differences. And it's also, it's also, while it focuses mostly on kind of axonal injury, perhaps it doesn't also capture some of this other microvascular ischemic related injury as well. So this is why I've been really focusing on FLAIR white matter hyperintensities. Now there's limitations to these as well. One being that these are non-specific lesions of the white matter, but they're often presumed to be of a vascular origin. So they're most commonly associated with aging and vascular risk factors, so things like hypertension and diabetes. And in fact, here, if you look at this this graph, it's a graph of the percentage of white matter hyperintensities and age, and you can see that as you get above 80 years old, about 90% or so, people have white matter hyperintensities. But the difference here is that the white matter hyperintensities, they are clinically routine. These are often evaluated in the setting of a dementia evaluation to assess for vascular related cognitive impairment. And they're not as, there's different methods for quantifying the total lesion load in research, but they're a little bit more reproducible, at least in my experience, across labs. And so we've been studying this in the setting of Alzheimer's disease, and this is CJ Puzo, who was a research assistant for the ADRC, I think like a year or two ago now, who's now moved on to Yale Medical School. But he led this study published in Alzheimer's and Research Therapy, where we use the National Alzheimer's Coordinating Center data set. And we found that that those who had more severe white matter hyperintensities at baseline among people with normal cognition had an accelerated cognitive and functional decline over time. So this looked at, this looked at over 7 visits of cognitive data as well as functional data, and you can see in this figure here with the I guess it's a yellow or gold line, that those who had the most severe white matter hyperintensities tend to have a more of an accelerated decline on their CDR over time as well. White matter hyperintensities have been extensively studied in Alzheimer's disease, for a while now. There's some debate on exactly their role in the disease. Some argue that they're from aging and vascular risk disease, and they have an additive effect on the presentation. Others say that it's part of the Alzheimer's disease pathogenesis. Others say that it's a downstream effect from the tau of Alzheimer's disease. I'm in the camp that says it's probably all 3 of these. Anyways, that is the debate. So I've actually been looking at these though, and wondering if they can capture some of these white matter microvascular pathologies associated with repetitive head impacts that I showed you. And so specifically here, can they capture some of that white matter rarefaction that we found in that paper in JAMA Neurology? Or maybe it can even capture some of the white matter pathology or injury that's a result of the tau from CTE. And I think this is, I get excited about this just because of how routine and practical that these scans are. And so that's something that I've been focusing on for a little while now. So this was published in 2018. This was in the DETECT study of former NFL players. That was led by, this was a study that Dr. Sterner was the PI of. But this included 86 symptomatic male former National Football League players. And there's also a group of 23 same age asymptomatic men without any history of repetitive head impacts or TBI. So as part of this study, they underwent MRI. The MRI was analyzed using FreeSurfer, and we used as part of FreeSurfer, it also spits out white matter hypointensity. So I call them white matter hypointensities because FreeSurfer used the T1 scans, and on T1 scans, these lesions are dark, so they're not bright like the flares. There's been some research that actually shows that these two methods are quite comparable, but at least clinically, the FLAIR is preferred, and because they're easier to see. And also there's research that says that the flares are more sensitive to picking them up as well. And then we also had a cumulative head impact index. So this was an index created a little while back that we applied to this sample of NFL players. And it's really just a measure of cumulative exposure to a repetitive head impact. It takes into account seasons of play, position, as well as helmet accelerometer head impact frequency data from the helmet accelerometer studies. While helmet accelerometer studies don't exist for NFL, we had to use college level accelerometer data. So this was the sample. Again, the two groups were similar in age. You had about 42% African Americans in the NFL, and unfortunately, just one in the control group. The NFL players played about 18 years. Their cardiovascular disease status is down here. I will say that we calculated the Framingham stroke risk profile for each group, and we found them to be relatively comparable, which is important to note because if we're trying to make inferences that these are from the lesions are from repetitive head impacts as opposed to vascular disease. And basically what we found was that the former NFL players did have greater volume compared to the greater volume of white matter hypointensities compared to the unexposed group, and that the cumulative head impact index, the more hits the head were associated more white matter lesions in the former NFL players after accounting for age as well as the Framingham stroke risk profile. And then clinically, we also found that these white matter hypointensities correlated with worse psychomotor speed, executive function in the former NFL players as well. And that's a domain that has consistently been shown to be associated with these types of lesions. So it was nice to see the consistency here with the literature. So as I mentioned, one limitation of this study was one, it was a relatively small sample. It was just former NFL players. And it also used the T1 scans as opposed to flares to look at the white matter lesions. So something I'm working on now as part of my K award is to better understand these white matter lesions in this setting, but specifically using flares. And so this K award actually has 4 aims. And I'm going to provide some preliminary results that are not published. But their 4 aims are 1, to actually another limitation of the last one too was we only looked at total volume. We didn't look at the regional distribution of those hyperintensities. There's a lot of work now in Alzheimer's disease, for example, that shows the Alzheimer's disease participants have a unique-ish distribution of lesions in a pattern where you might expect for Alzheimer's disease, so temporal parietal pattern. So here I wanted to look at the distribution of these hyperintensities in people at risk for CT compared to people with AD and those with normal cognition, understand the clinical consequences of the white matter hyperintensities in the people at risk for CT, and then also get a better understanding of what are the causes of these hyperintensities in a setting, teasing apart vascular versus neurodegeneration and so on, and including those from repetitive head impacts. So this study is using the Diagnose CTE research project that Dr. Stern leads. So this includes 3 groups of participants, including those former NFL players, 60 former college football players, both groups spanning the clinical spectrum, and then a control group which includes males, same age males, all asymptomatic, who have no history of TBI. So these groups really get everything done to them, including a FLAIR MRI. this design of the study has changed a little bit, I should note, just due to COVID. There's specifically a 3-year follow-up. I won't get into it now, but just for your reference. So we quantified total FLAIR white matter hyperintensities using the lesion segmentation toolbox. This is an algorithm, an SPM, developed using a sample of multiple sclerosis patients, and it seems to work pretty good in our setting as well. I know Dr. Kiliani's been using it for the Alzheimer's Disease Center. But this is just an example. So here's your native FLAIR of a participant on the top row, and then everything in orange is what the algorithm has identified as being a lesion. So you can see that it maps on pretty well. And it's also nice because it's completely automated. So it allowing for reproducibility as well. So there's not as much manual intervention as there. Another really nice part about this too is that it does not require a T1. So you don't have to co-register your FLAIR to a T1. You can, it's optional, but you can also get similar results by just using the FLAIR. So additionally to looking at total lesion volume, though, we also looked at regional FLAIR white matter hyperintensities in the groups, and we did this using FreeSurfer. So we took the mass T1 and T2 weighted scans. We processed them with FreeSurfer, and then we segmented the gray and the white matter. And then we took the white matter. We used the Deskin-Kiliani atlas, and we took the white matter atlas from FreeSurfer to identify the specific location of the FLAIR white matter hyperintensities. And the way that atlas works is that basically the white matter region is labeled based on its nearest cortical gray matter label. And then we registered that atlas to the FLAIR lesion maps from the lesion segmentation toolbox, and we calculated lesion load in frontal, temporal, parietal, occipital lobe, and we also looked at the corpus callosum, given some research that shows its effects from repetitive head impacts and also being the largest white matter bundle. And we mapped the loads using some, it's pretty straightforward, but through these are actually based on some FreeSurfer recommendations. Within the study, everyone also completes a battery of cognitive neuropsychiatric tests. It's a very comprehensive battery that covers all domains of cognition and behavior, mood. And then exposure, we're also looking at different metrics of exposure and association with the lesion. So we're looking at years of play based on what Dr. Mez found, but we also looking at age of first exposure, as we've seen younger age of first exposure to have long-term effects on clinical outcomes. And while we didn't see, in one study we published on this, we didn't see a relationship with tau pathology, we did see that the younger you start to play, the earlier you begin to have symptoms. So I know I'm running out of time and I want to get to the last part of the study. So I'm gonna go a little bit quick through this, mostly because this is also preliminary. But there were quite a bit of zeros for the white matter hyperintensities, particularly for the different lobes. So we did use a Tobit regression, which can help accommodate those zeros. And what we're doing is comparing the football players versus the unexposed and looking at their association with years of play and age of first exposure. We're controlling for age, vascular risk factors, as well as scanner site. So there are 4 scanners involved in this study, so we wanted to be sure we accounted for those. There is a little, we're running into a little bit of complexities here. This is just a distribution of the white matter lesions between the football players and the no football players. Like I said, you can see like in the frontal, parietal, temporal, you have a lot of zeros, but perhaps more of a distribution in the frontal lobe. The corpus callosum and total lesion volume looks like a nice distribution though of lesions. I'm gonna skip over this. But what kind of a quick preview into the results is that we are seeing or a trend for more lesions in the American football players, but specifically in those who are older, so those who are greater than 60 and not in the younger folks. And there also seem to be some frontal, temporal, parietal lobe specific effects as well. We also found a relationship between younger age of first exposure and greater white matter hyperintensities. This was in the full sample, but it looked stronger in those who are older as well. And there was just very strong relationships with all the clinical outcomes. So we still need to flush out a few things, and we're specifically interested in bringing in perhaps measures of cortical gray matter volume to see if exposure, years of play leads to atrophy, which might lead to these lesions. We've also begun to look at this in the Alzheimer's Disease Center, thanks to the work by Dr. Piliani in processing these. So this was a master's thesis of one of my master's students. And again, I'll just briefly cover this, but we took 84 participants from our Alzheimer's Disease Center. So our ADRC, as most everyone knows here, has a group of people with and without repetitive head impacts. And we age matched to the two groups to be plus or minus 5 years. In the RHI group, it was quite a diverse range of athletes, 23 football, 19 soccer, 10 ice hockey, 6 boxing, and so on. And really what we found was we didn't find much in the full sample, but when you restricted to just the football players, you all of a sudden had a really strong effect. And so that kind of suggests, I mean, it's a small sample, very preliminary. We likely won't yet move forward with publication till we figure more out. But it does suggest that maybe some of these other sports with less exposure might have suppressed the effects, and that maybe the football players are more prone to these lesions. All right, so I think I've now shown you some data and some consistent data that we see these lesions more in older American football players. They seem to be associated with exposure. But what exactly is the cause, or what's the pathological correlates? And this was work that's currently under review in neurology. And this was Madeline Uretsky, a senior coordinator at a study who led the study. And we used the Unite Brain Bank to look at the clinical, pathological, and RHI exposure correlates of FLAIR white matter hyperintensities in brain donors. So the Unite study has these, as you might have seen, has these two arms. Importantly for this study, on the left arm here is we get medical records from every brain donor. And as part of those medical records, we actually get MRI scans. So here we took all the brain donors who had FLAIR scans, and we processed them using the lesion segmentation toolbox that I just talked to you about. So we excluded people who had things like tumor or radiological evidence of stroke. Some of the scans couldn't be processed through MATLAB. Again, these are clinical scans, so it gets a little bit messy, and so we tried our best to really have clean scans. And so we even got rid of a couple of people who seemed to be outliers. One of those outliers actually had an MRI done on a 0.3T Hitachi, so it made sense to even get rid of them there as well. There was 2 scans where there seemed to be kind of gross mislabeling to the motion artifact. But anyways, we ended up with a sample of 75 after we really cleaned things up. And we looked at this sample to look at the correlates of the lesions. So this is a lesion segmentation toolbox again, what I just showed you before. This was a brain donor actually who had a clinical FLAIR scan available. This was actually one of the better FLAIR scans, as you can see, even though it was clinical. But you can see it did a pretty nice job. And what was great actually about it was even when there was motion artifact or just poor clinical scan acquisition, the toolbox seemed to still work pretty good. So Madeline and I went through each of these scans and rated them on a 0 to 3 scale in terms of artifact, 3 being severe artifact. And you can see even in some of these 3s, this is a pretty crappy scan, but you can still see that these lesions here are the pipeline's still working pretty decent. Who knows what some of this other stuff is, but it was still working okay. And so we decided not to toss these. We only tossed 2 cases where it was really counting like the bone or something, and we thought that it wouldn't be wise to include those. But even here, this was an example of ringing, and it still worked pretty good. So we did the neuropathological assessment was done. Just go through that quickly. The Unite Brain Bank, we also do the clinical assessments where the informants complete cognitive difficulty scale, the functional activities questionnaire, geriatric depression scale. Our data analyses, so we did a series of regressions looking at the association of these lesions with pathology, years of play, and the clinical scales. We controlled for age. There was also some variation in the time from MRI to death, so we controlled for that. Race, education, vascular risk, and we also took an extra measure and controlled for MRI resolution, although most of these were 1.5 T. So nearly all of these, about 75% of the sample was demented. There were about 67 on average. Most of them played football. About 90% of the sample were football players. And as I mentioned, about 80% of the scans were done on a 1.5 T. So the main findings here for the pathological outcomes was that these lesions were associated with both the white matter rarefaction and arteriosclerosis at death, as well as tau pathology. So both CT stage and tau in the frontal cortex. It was not associated with amyloid beta or other markers of cerebrovascular disease like atherosclerosis or infarcts. There was also a pretty clean relationship between the years of play and the lesions. So among the football players, those who played more had greater lesions on the scans. And here's just kind of an example to show as a way to show an example of the data. These are two football NFL players, both without vascular risk, both of the similar age, one with a lot of years of play, one with minimal years or a few years of play, and you can see the differences in the white matter lesions. And it was also had some clinical effects. So the white matter hyperintensities were associated with worse functioning and worse cognitive function as well. No effect for depression, although we do think that might be a result of the measurement of the GDS in the setting. So we're actually looking at different ways to perhaps assess depression in the Unite Brain Bank, as we're not finding much of this measure in anything, to be frank. So to wrap it all up, the exposure to RHI does seem to have lasting effects on the vascular systems. I'm pretty excited about the flares and their perhaps practical and routine practical way to capture some of this pathology and study it. Although the caveat being it is non-specific and it will be a challenge to tease apart what their causes are. But in general, I think this is a really promising path for research, as I think it opens up a lot of doors to prevention and therapy. There's hope that some of this might be modifiable through things like exercise or other kind of behavioral interventions, or maybe medicine. I'm really interested in the different pathways to explore. Does RHI lead to vascular that causes tau? Does the RHI cause tau, then lead to vascular? And you could do this in a whole bunch of different ways, but exploring these different causal pathways will be interesting. And that's why I'm really excited about this R1. Some might say I'm jinxing it here, but I'm going to go out on a limb. Ann McKee and I submitted this R1, is scored in the 20th percentile. And the purpose of it is to use both the brain bank and the ADRC to really do a deep dive into white matter degeneration and cerebrovascular disease in contact sport athletes. It's also in collaboration with UCSF, Dr. Gil Rabinovici, and the goal will be to get 300 living participants, 300 brain donors, and just do a bunch of in vivo assessments of the white matter and microvascular disease, as well as ex vivo assessments as well, to create this kind of nice resource to study these pathways. So with that, I just want to say, I did learn that I need a better acknowledgement section after making this, but I do want to say thank you to everyone at the Alzheimer's Disease NCT Center. It's wonderful to work with you all. You're great colleagues, and I really value my relationships with you. The Concussion Legacy Foundation plays a huge role in all of our work, and then of course all of the athletes, all the participants that participate in the studies, we couldn't do it without them, and so they are what makes our research happen. So I know I'm a little over, so I apologize, but also available for if you want to email me questions or whatever.